the difference between intra and extracranial stenting or angioplasty or treatment of intracranial atherosclerosis, I think we have to start with understanding the vascular histology. 1 centimeter from the skull base, the vascular histology changes from the extracranial to an intracranial morphology. And what is that morphology? Basically, there is lack of adventitia. The internal elastic lamina is more interrupted, not a smooth continuous layer. The blood vessels are not embedded in muscle, they're embedded in CSF, so it's obviously fluid. There are more turns, and all of these conditions make the blood vessels more friable and prone to injury. Okay, thank you, Jim. Make it more prone to injury when we do intracranial procedures. So epidemiologically, in the US or the West, 10% of acute ischemic strokes may have an underlying atherosclerotic etiology. Unlike acute coronary syndromes, which occur predominantly because of an underlying plaque rupture, vast majority of intracranial acute strokes, as we've already discussed all day, are embolic with the secondary source, central source, either the aorta or the heart. The incidence does vary by ethnicity. There is a relatively larger incidence of intracranial atherosclerotic disease in Blacks, Asians, Hispanic, Southeast Asia, and in some Arab countries. So we are in a belt where probably our incidence of intracranial athero is higher. The risk factors are the same as for any vascular disease. Hypertension and hyperlipidemia were the most important modifiable risk factors in the WASIT trial. And if someone had one risk factor, the prevalence of an MCS stenosis was 7% going to 30% with 4 risk factors. So similar risk factors, slightly different vascular histology. And these are the common locations of intracranial atherosclerotic disease. Carotid siphon is the most common. We see it frequently on our CAT scans. That's the most common place where we see calcifications. And typically it is less symptomatic, but we have to realize this is our access to the intracranial circulation. So atherosclerotic disease here, even if though not directly symptomatic, can be problematic when approaching, say for instance, the middle cerebral artery. Main trunk of MCA, distal vertebral artery. Again, if you look at CT scans of the brain, heavy calcifications are seen in the cavernous segments of the internal carotid arteries and in the intracranial extradural or intradural segments of the vertebral arteries. Vertebrobasilar junction is a common site of atherosclerotic disease in posterior circulation strokes. If there is an occlusion in the proximal vertebral artery, it is almost always secondary to underlying athero, which makes sense because if there was no stenosis there, an embolus would travel distally up to the distal basilar or top of the basilar. This is a histology of the intracranial circulation. There's thinner or absent adventitia. There's fragmented internal elastic lamina. There is no external elastic lamina. Vessels are suspended in CSF. And we see that a dissecting aneurysm in the cerebral circulation typically results in subarachnoid hemorrhage, whereas a dissection extracranially does not lead to a transectional or extravascular rupture. These are 3 classifications which are descriptive. Again, everything doesn't always fit neatly into these categories, but for whatever it's worth, a less than 5 millimeter concentric lesion is classified as MORI 1, 5 to 10 millimeter, possibly eccentric like in this middle cerebral artery, B, and then a tortuous segment more than 10 millimeter is classified as a C. The ICAD mechanisms are hypoperfusion, where there could be a compensatory vasodilatation and collateral. So diamog SPECT scans can be useful in undermasking or unmasking hypoperfusion syndromes. Local thrombosis at site of stenosis, similar to a coronary pathophysiology, can happen, which can present as acute ischemic strokes in maybe 10 to 15% of all cases. And then thromboembolic is common, less common. Then occlusion of perforating artery, especially in the basilar artery with a perforator-rich territory supplying the brainstem, is another mechanism. No randomized clinical trial has shown benefit for intracranial stenting for ICAD versus medical management alone. Some of the trials listed here: prospective phase 1 randomized, Neuralink, Visit, balloon-mounted stent. Sampras was a phase 3 randomized control trial, 70 to 99% stenosis, gateway balloon, and a self-expanding wingspan systems. None of these trials have shown conclusive benefit, unlike coronaries, that there is a benefit of intracranial stenting even for symptomatic stenoses. And that is because of the heterogeneity of these lesions and how they can present. Patient selection for ICAD is similar to LVO treatment. Stenting can be considered for hemodynamic compromise. For instance, our last patient we did was a post-CABG patient with a tandem carotid stenosis, M1 stenosis. Carotid was treated, patient did not get better, labile pressure-dependent symptoms, and so we stented that patient. Medical therapy, hemodynamic, especially important for embolic disease to prevent distal emboli, and the medical therapy in this case is again antiplatelet therapy, typically aspirin, clopidogrel. But if you look at the heterogeneity, this patient and a minor M1 occlusion in these trials were grouped together, which causes probably some of the reasons why these trials don't show benefit. Now, this patient with possibly labile symptoms is not going to do well with medical management alone. I will skip this. This is a post-market, most recent trial or study, post-market study. It was FDA mandated after the negative results of Sampras. It's prospective single-arm stroke or death within 72 hours, typical criteria for inclusion. 70-90% stenosis, refractory to medical management. This is important. You could not do this procedure within 7 days after the stroke. So even if the patient was labile, you could not treat for this registry. Recurrent 2 or more strokes, still after 2 or more strokes, the baseline MRS should be less than 3. And it is very strict criteria, difficult to enroll patients. The audience here, you would not wait a patient having first MI, a second MI, and then treat the patient. And the patient still has to be alive after suffering 2 heart attacks. So the trial concluded, basically there was a low peri-procedural rate of 2.6%. The current US indications for wingspan, which is the only device under humanitarian device exemption, is 2 or more strokes despite medical management, has to be 7 days prior to the treatment, more than 70% stenosis, and baseline MRS of 3 or less. This is a algorithm. So first presentation with some neurological symptoms, you do assessment, CT, DSA. If the patient is symptomatic, minor stroke or TIA, versus large symptoms, acute ischemic stroke versus asymptomatic. If the patient is asymptomatic, obviously the patient goes to medical management. In a symptomatic patient, acute ischemic stroke, acute intervention is indicated. In a symptomatic stable patient, meaning the patient is not labile, you can consider medical therapy. If the symptoms recur, then the patient goes to acute intervention, or if the patient is unstable, labile symptoms, the patient goes directly to acute intervention. This is an example of proximal athero resulting in acute stroke. The patient was initially treated with angioplasty, Mercy, heparin, and then patient was stented 3 days later after dual antiplatelet therapy. This is an M1 stenosis with corresponding hypoperfusion as a mechanism of presentation, was treated with wingspan. This is a patient with vertebrobasilar, again, proximal stenosis, which these patients present with acute ischemic stroke. This patient was treated with wingspan. I'll just quickly show why there are more complications with a self-expanding stent after angioplasty, because we require an exchange length procedure, which is very difficult in long wires in the intracranial circulation. So this is a gateway balloon, angioplasty ×2. Then we have to take the balloon off and bring the stent up This is a wingspan, self-expanding stent, and deploy the stent. The rationale behind the self-expanding is low radial force, less traumatic to the cerebral circulation. This is, I'll just quickly show petrous stenosis. We did SPECT in this case to show that the vascular reserve was compromised. The patient, 6 French access wire. We tried the gateway balloon. The intent was to do wingspan because it was an on-label indication. The balloon watermelons quite a bit distally and proximally while we're holding it in place. And you can see the guide catheter even ride higher because there was so much tension and proximal pull applied on the balloon. Anyway, do the angioplasty, and the result is it's more hazy with worsening underlying stenosis. So at this point, I said we're not going to go through that exercise again. We take a balloon-mounted coronary stent, bare metal, and deploy with one inflation, which avoids the use of exchange length procedures. So conclusion, evidence does not support primary ICAD intervention like it does for primary PCI. A trial of medical management is warranted in stable patients. Labile patients, lesion evaluation such as lesion length, vascular access, perforator-rich zone is critical. There, if the atherosclerotic segment is 2 millimeters away from a perforator-rich zone, the complication rate is dramatically lower versus in a perforator-rich stone. Angioplasty alone should always be considered. Undersized balloon, 60 to 80% of vessel diameter, and very slow inflation over 2 minutes or so is safer. Self-expanding versus balloon-mounted is lesion-dependent. Thank you.